Dear viewers, welcome you all to our show, Orthopedic Solution Academy, OSA. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is Hemimelia, magically treated by Ilizarov. And our speaker is the very magnificent speaker from India, Professor Ruta Kulkarni, the present president of OSA India. I would like to request Professor Ruta Kulkarni ma'am to join with us.
Good afternoon. I must thank Dr. Tanvir and Professor Bari for the kind invitation. I bring greetings and best wishes from Assam, India. So today I'm going to talk about Hemimelia.
Ma'am. Definitely. As before that, we want to introduce our another speaker, that is Professor Novikov sir from Russia. I would like to request the highly academic person, Professor Novikov sir from Russia. Good afternoon, sir.
Good afternoon, dear colleagues.
Good afternoon,
sir.
Dear viewers, we have academic expert with us. One of them is the pioneer Ilizarov surgeon of Bangladesh, Professor Mufakkarul Bari sir, the legendary Ilizarov surgeon of Bangladesh. I would like to request Professor Mufakkarul Bari sir to join with us.
Thank you, Tanvir, for introducing me. Thanks all the colleagues.
Thank you, sir. And we have Dr. Shamsul Huda, another academic expert from Patna, India. I would like to request Dr. Shamsul Huda, sir, to join with us.
Good afternoon, and thank you, Dr. Tanvir.
Thank you very much, sir. Dear viewers, we have two academic experts, one from Jordan, Professor Ramai, and one from India also, Dr. Amar Sani. But due to some unavoidable circumstances, Dr. Amar Sani can't join with us. But Professor Rami sir is with us. I would like to request Professor Rami sir to join with us from Jordan. So welcome to our Orthopedic Solution Academy. Thank you very much, sir. First, you have to unmute yourself so that we can hear you, sir. Professor Rami sir.
Yeah, good afternoon. Thank you for inviting me.
Thank you.
You're most welcome, sir. Dear viewers, we all know that hemimelia is a very challenging thing, but we can manage it magically by Ilizarov. But how? And that will be discussed today. I want to request a very magnificent presenter from India, Professor Ruta Kulkarni ma'am, to start his presentation and to share his screen with us. Ma'am, would you please share your screen with us?
Yeah. Okay, so is this visible?
Yet not visible, ma'am. It's coming. It's coming. Yeah, it is absolutely fantastic.
Okay,
we
good.
can see your slide and we can hear it clearly. Please, ma'am.
Okay, great. Okay, so hemimelias in lower limb, both tibia and fibular hemimelia. Just a second. How to proceed further? This is not easy. How to go behind? So hemimelias, both tibia and fibular hemimelia, are rare congenital anomalies, and they are characterized by severe deformities and shortening. Actually, amputation was and still is treatment of choice in many of these. But salvage is definitely possible now with proper understanding of the deformity. So I'll talk about tibial hemimelia first. So out of 2, tibial hemimelia is even more rare. It's 1 in 1 million. and it's more severe. And the variation in dysplasia is very wide. So there are many classifications. I use Jones classification. So this is Jones classification of tibial hemimelia. In Jones type 1A, there is complete absence of tibia and there is absence of extensor mechanism also. And the distal fibular epiphysis is abnormal in this type of hemimelia. So this is the type where amputation is commonly prescribed. But there are some people who transfer the fibula under the femur and leave it as it is, and with the help of a caliper, the patient can walk. Or even people fuse the fibula to the femur. In Jones type 1B, the proximal tibial epiphysis is absent at birth, but it is not actually absent. It is cartilaginous and eventually it ossifies. The extensor mechanism is functioning, and the most important thing is that the distal femoral epiphysis in this is normal. So if you compare 1A to 1B, 1B can be salvaged with Ilizarov. So I had this patient. You can see this girl has complete absence of tibia. She is just 2 months old. She came to me with such severe deformity. If you see carefully, her distal femoral epiphysis is normal and she had functioning extensor mechanism. So this was not 1A but Jones type 1B. So actually you can't see any tibial remnant or tibial enlarge, proximal tibial enlarge in the X-ray. But if you do an MRI at this stage, you might be able to see a cartilaginous enlarge in the proximal tibia. So I decided to salvage this limb, and at the age of around 1.5 years, I did this supramalleolar osteotomy. I did a soft tissue release, and I brought the foot under the fibula. And then I casted this girl for a pretty long time. So at the age of 2.5, you can see the proximal tibial enlarge ossified. So this is the stump of tibia. At the age of 3.5, I decided to cut the fibula and bring it below the tibia. You can see the foot which I brought under the fibula was sitting right there. It was nicely sitting below the fibula. So I brought the fibula and below the tibia and put a nail from the foot into the fibula into the tibia. And I kept this nail for a pretty long time. So at the age of 4, you can see the fibula has now become tibia very nicely. The foot is sitting below the fibula, which has now become tibia. So this is follow-up at the age of 6 years. So at the age of 6 years, the girl can not only walk, but she can even dance with the help of orthosis. She has absolutely stable knee, stable ankle, fully mobile knee and ankle, and she has developed about 5 centimeters of shortening. And she could even wear normal shoes. So I decided to lengthen her at the age of 10. And I also did an epiphysiodesis of the proximal fibular stump. So I did 6 centimeters of lengthening, a very cooperative child. And at the end of lengthening, I corrected her foot deformity. She had a little varus and I corrected it. So that was her foot. And this is at the age of 11.5. You can see the fibula has now become tibia very nicely. And she has fully functional knee and ankle. And fully plantigrade foot. And this is how she is walking very nicely. She can actually ride a bicycle, she can jump, run, and play sports. Coming to tibial hemimelia Jones type 2. The Jones type 2 are little severe ones. There is absence of distal tibia, and there is very, very severe equinus of the ankle, and there is huge amount of shortening also. So this 6-year-old girl came to me like this. You can see there is absence of distal tibia, and look at the equinus. The foot is actually sitting behind the fibula. and the equinus is extremely severe. So this foot cannot take part in wet bearing. So I did the same surgery, tibialization of fibula, I did a soft tissue release, and I brought the foot anteriorly. And her equinus was corrected to great extent. No, though not fully, it was corrected. So now the foot is in the line of tibia, and this can take part in weight bearing. After 2 years, I lengthened her tibia with the technique which I have developed and published, lengthening over plate. So I lengthened her, 4 or 5 centimeters of lengthening was done, and this is her final X-ray. So she came to me at the age of 17. So you can see she has still equinus, but she can bear weight on this foot. I offered her correction of foot by doing an ankle fusion, but that would have led to 12 centimeters of shortening of her leg, and it would have needed 2 more lengthenings. So she opted for not going for correction. She was quite happy with this. She could bear full weight on this foot, and she used a caliper. So you have to honor the wish of the patients. Now coming to tibial hemimelia Jones type 4, tibiofibular diastasis, and there is a rotational deformity. There is also ankle equinus and shortening. So this is very typical Jones type 4 tibial hemimelia. You can see the rotational deformity in the fibula. The fibula is way anterior to the foot again. So this child has Jones type 4. You can see the equinus. And this is his father. His father had bilateral tibial hemimelia. He was walking on his knees all his life. Okay, so I excised the distal stump of fibula to correct the equinus because the fibula was so anterior. It was obstructing the correction of equinus of the foot. So I excised the distal stump. I corrected the rotational deformity and I lengthened the tibia. So that's his final X-ray. Complete correction of equinus you can see here. Now I come to fibular hemimelia. Fibular hemimelia is complete or partial absence of fibula, and there are deformities everywhere in the foot, in the tibia, in the knee and femur. So foot has severe equinovalgus. The ankle can be completely stiff or it can be unstable. There is usually tibial bowing and shortening. So this is an old paper by Noddy. He said that the recurrent of residual foot deformity is the prime reason for unsatisfactory results. So Dr. Pele has come out with a classification which largely depends on the foot deformity. So I have published this original article in the JPO, Journal of Pediatric Orthopedics, use of Pele's classification and super ankle procedure in the management of fibular hemimelia. So according to Pele, the type 1 has stable ankle. So this girl has stable ankle. There is complete absence of fibula, but her ankle was stable. So in this patient, all you have to do is just lengthen her tibia and she was fine. In type 2, there is a dynamic valgus deformity of the ankle, the classical ball and socket ankle. So this is a ball and socket ankle. You can see this boy had 3 centimeters of shortening and absent lateral 2 rays. So I did 3 centimeters of lengthening, and to correct his ball and socket, I did a supramalleolar dome osteotomy, which includes tibia and fibula. So the varus was converted into a valgus ankle. Sorry, the valgus was converted into a varus ankle. So this is his 2 years follow-up. And this is when he became 16 years old. You can see he has plantigrade foot, but he still has a little amount of residual ball and socket ankle. So I have offered him again a supramalleolar osteotomy, which will convert his valgus into varus. Coming to type 3. Type 3 are the most severe types of fibular hemimelia, and there are subtypes also. In type 3, what is recommended, the surgery recommended in type 3 is called as super ankle. And the super ankle involves these steps. Usually, Paley has recommended to do all these steps in one sitting, but I do it in 2 stages. So we have to do radical soft tissue release, resection of fibular enlarge. Again, Paley resects the entire fibular enlarge up to the fibular head, but I do it only at till the level of fibular bow, apex of the tibial bow. Then you have to go for subtalar or supramalleolar osteotomy if needed and align the foot. Then I do this in one stage, and at a second stage, I do tibial bow correction and lengthening, usually after the age of 3 to 4. So in ankle, in type 3A, the deformity comes from ankle. So the fixed equinovalgus is because of ankle deformity. Like in this, you can see the ankle orientation is giving rise to equinovalgus. So you have to do lengthening and a supramalleolar osteotomy and re-lengthenings whenever necessary. Coming to type 3B, which is the commonest, actually 3B are the commonest. And in this type, the talus and calcaneus are sitting side by side instead of one below each other. And the deformity comes from the subtalar joint. So this is type 3B. You can see here, this is the normal alignment of talus and calcaneus. And here you can see calcaneus is sitting lateral to the talus. So you have to correct that. So in first stage, I do super ankle. I do complete soft tissue release of fibular enlarge, and subtalar joint has to be released completely. If there is coalition, you have to do an osteotomy and bring the calcaneus below the talus and fix it. So I do this as a first stage, and at second stage, I do correction of tibial bow and lengthening. So this is his 2-year follow-up. This is when he became 10-year-old. This is his X-ray when he became 12 years old. You can see there is some internal torsion and 3 centimeters of shortening. He had 3 centimeters of shortening. So he came back at the age of 14. There was again 4 centimeters of shortening and internal torsion. So I decided to lengthen him. I did a derotation and a lengthening of 4 centimeters. So that was the result. So this is when he became 16 years old. See, the knee is fully mobile. His ankle and foot are fine. But he has developed, I mean, it was there since a long time, valgus in the knee. The valgus was present in the distal femur. And again, he developed about 3 centimeters of shortening. So at the age of 18, I did a supracondylar osteotomy and corrected his femoral valgus. And I did lengthening in tibia, this time with a technique of lengthening over a nail. And that's his final X-ray and final picture. So I have his follow-up of almost 20 years. So this is how his leg looks now, perfectly fine and functional. Coming to type 3C. Type 3C are the very severe types, and very commonly they are advised amputation. In type 3C, the deformity is present in both ankle and subtalar joint. So this child had fibular hemimelia type 3C on right side, and on left side he had CTV. You can see his deformity. He had all these deformities. He also had distal femoral valgus, femoral shortening. So in first stage, I did a super ankle procedure, as I described before. And I did osteotomy also. Then he came for follow-up in 2002, you can see. And I applied Ilizarov to correct his tibial bow. This is 2003. And that was the result. I could correct the tibial bow to some extent. He came for follow-up in 2004. So his tibial bow was okay. His foot remained completely subluxated laterally. But he had femoral valgus and shortening. So I decided to correct his femoral valgus by using an orthofix device and lengthen his femur. So this was in 2006. You can see he has good lengthened femur. His femoral valgus is corrected. His tibia is okay, but the foot remained in equinovalgus. So this was his clinical picture. So his equinus was actually giving him length, and he had fully functional knee. So he was wearing this orthosis, and he could not only walk, but he could run and jump in this orthosis. So he was regularly coming for follow-up, but after this, I lost his follow-up, and then he directly came when he became 17 years old. So you can see he's still wearing this kind of orthosis, and this is his X-ray. His femur was okay, but his tibia has mild valgus and procurvatum. His foot is still on the lateral side. So this is his clinical photo. You can see he has developed a huge amount of shortening, actually more than 12 centimeters of shortening, and his foot is in valgus. So I gave him the option of reconstruction by doing an ankle fusion and doing lengthening of 12 centimeters. But again, he refused, and now he wants an amputation. So I'm showing this case because you have to respect choice of the patient. Not every time reconstruction is a feasible option. Sometimes you have to consider amputation option also, especially in these very severe types 3C. Type 3D has Taylor type. I don't have a case of type 3. Type 4, palliative 4 again is a very rare occurrence. This fibular hemimelia has corrected along with it. So I had one such case. This boy had a lot of flattening and his foot was supinated, absent lateral raise. You can see short fibula here. So I did a soft tissue release to correct his foot and did his lengthening. So though he developed a little rocker bottom, he was actually weight bearing fine on him. So I have excluded fibular hemimelia who had less than 3 rays. So less than 3 rays is very insufficient weight bearing surface. So I offered them amputation. And those who had predicted limb length discrepancy more than 25 centimeters. So these are the 2 patients where amputation is a good choice, but otherwise you can definitely salvage fibular hemimelia. So to conclude, I can say that with proper understanding of deformity, salvage of limb is definitely possible in selected cases. Thank you for your kind attention. Thanks.
Thank you very much, ma'am. Thank you. Yeah. Thank you very much, ma'am, for your excellent presentation. We all know that hemimelia is a very rare case, and according to the classification, it is very rare to classify the hemimelia. But ma'am showed his presentation, her presentation according to the classification. I think it will help us a lot. Now, I would like to request our second presenter, the highly academic Professor Novikov sir. Sir, would you please share your screen with us? And after this presentation, we will discuss the topic and we will open up our question and answer session there. Yeah, yes. It's absolutely clear, sir. And the slide is fantastic. We can see your slide, sir. Sir, Professor Novikov, sir, we can't hear you, sir. Could you please speak something? The slide is fine, sir, but we can't hear your voice.
And now my voice in the way.
Yes, sir. We can hear you, but the slide is gone, sir. It's coming. Slide is coming.
Slide is coming.
Yeah. Yeah. It's okay,
And
sir. Fantastic.
Good afternoon, and thank you very much for Dr. Rukta for excellent information about this severe heavy pathology. I won't continue it, and let me remind you about this year, about celebration of our father apparatus and our center, and what is our methods of Ilizarov: almost bloodless and low invasive surgery, firm fixation of bone fragments, early weight bearing of the affected limb, function of the adjacent joint, just operative adjustment of the bone fragments from the time of surgery till the removal of the frame. And many years ago, Dr. Barrett says this frame provides happy balance between elasticity and stability, and its biomechanical factors adapted to bone allow to achieve amazing recovery. And we can talk about Ilizarov apparatus, we can talk about Ilizarov methods, but doesn't matter which kind of apparatus doctor use. Very important effect of Ilizarov, with which we can get great positive result. And for me, Ilizarov, this is our family, our father, our teacher, our coach, great person, big politic. And according of topic of our presentation, fibula hemimelia and tibia hemimelia, very rare congenital disease. And with fibula hemimelia, we use Kalamchi classifications. And in tibial hemimelia, for me, I prefer Jones classifications, because for me, little bit heavy in other classifications. And currently, orthopedists do not have a common options in the approach of treatment of this category of patients. Still, and with these classifications, I am prefer Kalamchi than Paley, little bit big one. And topic of today presentation, I want to analyze the different methods of transosseous osteosynthesis using Ilizarov technique in children with severe congenital anomalies of the lower extremities, for achieved by pendle stents, correcting dislocations, removal of multiplanar deformities, compensation of shortening, and preservation of lower limbs is an alternative to amputations. And with clinical characteristics, this is expressed flexion contracture of knee joint, subluxation or dislocation also of tibia, multi-component deformities of feet, unsupported lower limbs, inability to use lower limbs for movement in an upright position, uncomponented diagnosis. Indications for operative treatment according to the Ilizarov methods: inability to use lower limb, absence of skills to movement in an upright position, and propose of surgical treatment by the methods of Ilizarov: eliminations of flexural contracture of knee joint, correction of luxation and dislocations of legs, eliminations of deformity of feet. Unresolved issues: age when is necessary to start treatment, the amount of surgical intervention, ineffectiveness of conservative treatment, absence of continuity of operative and conservative methods of treatment, long-term rehabilitations. And policy of the center, Ilizarov, policy of my center, God's preservations of a limb. Operative treatment of patients in an early age for the development of uprightness skills. Maximum use of the patient's resources to achieve the planned result. In democratic Western countries, for the patients, the gold standard of treatments is amputations of problem limbs with subsequent prosthetics. My personal options, this is business, and I'm willing to spend time to routine and time-consuming manipulations. But an orthopedist can save a limb to a child. The orthopedist has no right to deprive the patient of what is given by God. The philosophy of the Ilizarov method is to correct the deformity and save. At present, there is no consensus on the choice to tactics and the type of treatment. Some of support, this is only social support, conservative treatment, and operative treatment. And what is better? Do not touch, do not operate, and only bracing. Amputation for the convenience of prosthetics. No operation, but no leg. Only one operation, but no legs. And surgical treatment, multiple operations, but their own legs. I still cannot answer what is better. Different approach to the treatment of severe orthopedics pathologies of the lower limbs. And you can see, for example, this is support, and in many countries, so many patients has only this support. In other way, and Western country says this is gold standard. I am agree. I am sorry. I am against. I am against. This is black standard. This is black business for the patients, for the doctor. How we can remove legs and remove future, I cannot understand. And in other way, treatment by Ilizarov, strange, long, but we can save this leg. Still, there is not main options how to treat. And Ilizarov give us key for open this lock. Our guiding philosophy, prosthesis in the congenital absence or traumatic loss of limbs? Of course, yes. And amputations and then prosthesis? No. Disadvantages of surgical treatment. For subsequent prosthesis, amputations, for me, this is problem of is the moral and ethical plan. And my personal options, this is business and nothing more. The discussions of the parents is primary. The doctor is only of sources of information. And the gold standard of treatment determines life, not the doctor's decision, sorry. The final choice of the methods of treatment is determined by the patient's parents, not doctors. This is my personal opinion. And Ilizarov changed this situation. But like any methods, our methods has disadvantages of treatment. Operative treatment is the method of Ilizarov. And our problems. First, this is time. Possibility of soft tissue. Communication with patients. The main problem in the preoperative period is a critical assessment of the potential capabilities of our young patients for a large volume of surgical intervention and long-term treatment. Assessment of the patient's readiness to cooperate in the postoperative period. And the orthopedist should think it is ready. Is he ready and able to go with the patient this long way? Because the operation is only the first step along the way. And surgical treatment in children with severe congenital anomalies of the lower limbs retain its key importance in the process of their long-term medical and social rehabilitation. And I won't show only few patients. 7 children from 11 months to 8 years. And a little bit later, I will explain why. 4 patients did not use the lower limbs. 3 patients used orthopedics device. Initial shortening at first admission ranged from 4 to 13 centimeters. 5 children had previously surgery of the soft tissue component in other clinics. And all of children were consulted in the best children's orthopedics centers in England, Israel, Germany, Austria, Iran, Russia, Ukraine, with the only one verdict. And it was one recommended: amputation followed by prosthesis. And I want to show a little bit clinical example. Patient fibula hemimelia type 2, first admission 11 months, and during 2 stages with 9 centimeters lengthening, and save this pretty legs, pretty girl. In England, doctor recommend amputate. Another guy with type 2 fibula hemimelia, first admission was in 3 years old, and during 4 stages we get 18 centimeters. He has only 1 ray, and with 1 ray he can full weight bearing. And just now I believe we will not amputate with his growing, because maybe in the future print of artificial foot will help us. Patient from Ukraine, fibula hemimelia type 2, and during lengthening or during treatment we get more than 20 centimeters. Just now, this is old pictures. Here she has only 11 centimeters, but on the final, just now more than 20. Another guy, this type 2, first admission was in 8 years old, and we gain of the 20 centimeters of lengthening. And tibia hemimelia, first admission in 11 months. In the first stage, we correct of foot deformity, then synostosis of proximal tibia and fibula, corticotomy for lengthening, and centralization of the foot. So many stages, so many surgeries. And just now, this is patient can walk, and like patient with Dr. Ruta can dance, can use bicycle. Another very interesting case with tibia hemimelia, both of legs. First correction of knee and ankle deformity on the right side, on the same surgery on the left. and correction of deformities there, and reconstruction of ankle joint on left side, achieve distal tibia fibular synostosis, relocated and stabilization of the ankle. And this picture I want to introduce Dr. Shikhaleva. She will next Friday with us with excellent presentation on the hand. And I'm very sad because this is a patient, unfortunately, died in a car accident with excellent orthopedics result. And last clinical example, baby from Kazakhstan. Before treatment, she cannot walk. And colleagues, look in the eyes of this child. And now imagine that there, the eyes of your child or the child of your relative. What will be your recommendation? To amputate or save a child's leg? She has aplasia of the tibia, dislocation, everything with type 1, what patient has. She cannot walk. And main task of this stage is the verticalization of the patient and walk in prosthesis. Before treatment, patient can walk only on the knees or on the buttocks. She cannot stand, even the assistance. Both limbs in was proper site proposed to amputate. Our funny surgery, osteosynthesis of femur, tibia, foot, correction, long period. And when we finished first leg, we spent near 3 months for that, because possibilities of soft tissue limitator and stop us. And with this support on the right side or for the left leg and lengthening and new position on the right side, we cannot discharge and how a patient will walk. And without rest, we haven't another choice. We start treat second leg. So many metals, but after a few months we will remove this metal and patient will continue. And again, please see in your eyes, she is smile. She walk without any support during the treatment. Another leg we finished with 1.5 months, and the patient can't walk without additional support. Before and after surgery, I think without any comments. All children continue to be treated. Currently patient age from 2 to 13 years, and we have achieved a significant reduction children's stay in hospital. Our experience has allowed us to increase the interval between stages of treatment. The remaining shortening is compensated by arthrosis. The need for the rare treatment was due to the abnormal development of the affected limb. We do not agree with the term replay in these children. Abnormal skeletal development is due to anomalies in development program. We cannot reprogram, we only eliminate the consequence of the abnormal development. Multi-stage treatment by Ilizarov in children with severe congenital anomalies of the lower limbs still remain the last chance to save from amputation. All parents of our patients are willing to bear the heavy burden of the long-term care, which every time, like any surgery, carries current risk. They also opposite rapid treatment by amputation, the essence of which can be reduced the principles of the no legs, no problem. And parents of our patients are willing to bear the heavy burden of long-term care, which every time like any surgery. Only one example of Olympics from South Africa are used to point out the advantage of amputations, our limb preservation. And final choice to the patients. If patients want to save their leg, we should be ready to help. Ilizarov methods allow to eliminate severe flexion contraction of the knee joints, verticalizate patients, and they create stability in the knee joint. Surgical treatment by Ilizarov improved the quality of the life of the patients. And what is better? Remove, run, jump, or stay with on leg. I prefer last picture. And finished, I want with a few words from one doctor from Islamic country. Ilizarov feel any defect of life of bone. When you are hopeless in orthopedics treatment, think to Ilizarov. Extended the quality of life by Ilizarov lengthening. When all lights are off, the light of Ilizarov is on. Surprising, unbelievable event by Ilizarov. The end of disability by Ilizarov. Bright future in disability by Ilizarov. Dr. Maradi from Iran. And Ilizarov, this is man, the myth, the methods, and orthopedic inspiration and miracle of the nature. This is our great colleagues. This is planet. This is monument. This is conference with his name. This is place of worship. And thank you very much for your attention. And I invite for cooperation and continued with our information many years in the future. Thank you.
Thank you very much, sir, for your excellent presentation. Yeah, you're absolutely right, sir. When there is no light, there is a light of Ilizarov. And I would like to request Professor Mufakkarul Bari, sir, to share his knowledge regarding the hemimelia that can be magically treated by Ilizarov. Professor Mufakkarul Bari, sir, would you please share your knowledge with us?
Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yes,
You
of
can
course.
hear me. Okay. Very fantastic. I must congratulate Professor Ruta and Professor Novikov for beautifully presenting the very difficult case, tibial hemimelia and fibular hemimelia. You know, we are getting this kind of patient in our country very often. Still, I have in my place 3 cases of tibial hemimelia and 2 cases of fibular hemimelia at this moment. And what I would like to say, the Professor Ruta rightly mentioned everything. But in my life, what I have seen, if I counsel the parents regarding the amputation, they never agree, never. In my life, I have not seen. Whatever may be the deformity, if Ilizarov in your hand, you can rightly, fantastically, gradually, you can correct all these kind of severe deformities. Regarding the tibial hemimelia, I rightly follow the Jones classification, which was mentioned by Ruta and by Novikov. Very easy. There are lots of classification. Whatever may be the classification, your target is to go for deformity correction, lengthening. It takes time, but everybody wants his or her leg so that he or she can move with his leg. And it takes time. Counseling is very important. I am very much impressed by both of the lecturer, nicely told everything elaborately. And this is the learning for the, learning for the all young budding orthopedic surgeons, because tibial hemimelia and fibular hemimelia, what I have seen in Kurgan, their suggestion is don't go for Allah or God has given you something, you try to keep it and you can do it. And with Ilizarov technique, you can do that. And we are doing that. And the cases shown by Ruta and shown by Novikov, I am really impressed how to go for that. And Ruda showed one case, 20 years follow-up. Nice. And ultimately, after 20 years, the patient wanted to go for amputation. If you can counsel that patient, I think now after 20 years, it is very easy to correct the, initially it was very difficult. Sequentially, you have corrected everything. And Novikov showed the different difficult cases. You have also shown the difficult cases. Really, I have learned a lot of things from both of your lectures. We are fighting all the time. In India, a lot of populations. And in my country, a small country, but 17 crore people, we are getting a lot of cases here. And our target is to do something for our poor, middle class, even the rich people, so that we can do something for these kind of deformity patients. Thank you very much again. Okay, thank you for your nice deliberation.
Thank you, Professor Wari.
Thank you, sir.
Thank you, Barry. Thank you.
Professor Novikov, sir, do you have, and Professor Ruta ma'am, do you have anything to say regarding Professor Novikov, sir, presentation?
Can I ask one or two questions,
Ruta,
Professor Novikov? If you don't mind, can I ask?
Yes, ma'am, please.
Why not? Yes,
Yeah.
of course.
Yes, please,
Yeah.
ma'am.
So in the last case of fibular hemimelia, Jones type 1A, with the bilateral case, so you brought the fibula below the femur. So did you fuse the fibula with the femur?
No. We only correct, release soft tissue, and we not fusion. And
so what about stability?
After surgery, she used braces. She used brace and walk only with brace. But her knee joint, this is unique patient. Only one patient we have like that. But both of leg still ready for weight bearing. But sorry, only with brace. You're absolutely right. She cannot walk without support. But we operate her only one time. This is, I cannot answer why. Because problems not back again. But from surgery till this time, she each day use brace. Many times brace is used, but this is situation enough. You see, our treatment only one type of treatment. This patient needs so many support in the rehabilitation, and I'm happy because just now she in the hand of excellent rehabilitation, in excellent physiotherapist. and
does she have
can
any
support
movement
with
of the knee?
conservative treatment. Then,
Does she have any movement in the knee?
yeah, of course, she can
The
bend.
knee movement.
She can
She
bend,
can bend.
but she can bend unbend only with support. She cannot unbend with herself.
Yeah. Okay. I have one more question. In fibular hemimelias, the severe fibular hemimelias, do you do open soft tissue release to correct the foot deformity as I showed? Do you do that, or you never open?
You're absolutely right. Few years ago, we never opened, but just now we can see with open surgery, with release problem of soft tissue, our result is more better. And I am agree with you. If we have problem with soft tissue, we release. And one more, if patient has severe stiff deformity of foot, we never start lengthening. Sometimes we go to shortening because small deformity more big problem than big shortening, more worse. And first we need remove deformity. And for
Correct.
that, better if we will release. I am happy because I work with Shikhaleva. Her husband is plastic surgery, and when we go to the in operation theater, if any patient has a problem with soft tissue, first plastic surgery remove problem soft tissue. Then I am continued with apply Ilizarov frame. But just
Yes,
now,
I
without
totally
good
agree.
condition of soft tissue, we cannot get excellent final functional
Absolutely.
result.
Yes, I totally agree.
I'm
So I
agree with
want to
you.
highlight this. Want to highlight this, that in fibular hemimelia, the foot stiff equine valgus of the foot should be corrected first. So
Right.
lengthening is not the
You're absolutely right.
important thing. You have to correct the foot first, and then go
Yes.
for lengthening. Yeah.
Right. Absolutely right.
No,
So thank you.
correct your foot, and
Yes.
if tibia has deformity, must correct deformity of tibia.
Okay, thank you very much, sir.
And
That
just
was a
now
great
we
discussion. Yeah, please, sir, please, Navikov, sir, please continue.
And just now, you see, we need start work like team. And orthopedic surgeon only one member of team. Without rehabilitation, we cannot get. Without plastic surgeon, we cannot get result. Without radiologist and maybe in the future some meeting, we need to spend time for regeneration. Without radiologist, we cannot get excellent result. And when we work together shoulder to shoulder with different specialties, our result just now absolutely different a few years ago. And I am happy because I work with team. I am not alone.
Agree.
Thank you very much, sir. Yeah, we are also a team of Orthopedic Solution Academy, and we are learning knowledge, we are gathering knowledge from each other. And now I would like to request Dr. Shamsul Huda sir to say something.
Thank you, Dr. Tanvir, Ruta ma'am, and Navikov sir. This was an absolutely mesmerizing learning for us, treating so many difficult cases. And I really get inspiration for this. And Navikov sir rightly said that Ilizarov can give life to any defect in the bone. So this is very good learning. Thank you, sir. Thank you, Pari sir.
Thank you. Thank you, everyone.
Thank you
Ruta,
for kind word.
Tanvir, and Dr. Rami, he's here. Pediatrics orthopedic from the University of London.
No, I think he left, sir.
I left? No.
Yes, sir. I think he left.
He left. No, he's joining every
Yeah,
day and
Professor
learning.
Jami, sir, are you there, sir? Yes, sir. I think he left a few minutes ago. Okay, dear viewers, I hope you gathered some knowledge from our two excellent speakers. That is the Hemimelia Magically treated by Ilizarov. And it is a great day, I think, as because of the Hemimelia is a very rare thing. And we know many things from our two learned speaker and our academic expert. So I would like to thank all of them for coming to the Orthopedic Solution Academy, and hope we will gather knowledge from Orthopedic Solution Academy. Hope we will meet in the coming Friday with our new speaker and new team. Till then, I'm Dr. Mohammad Tanvir Ashraf. Thank you all and giving bye-bye to everybody. And before that, I would like to thank Raj TV for helping us to arrange this type of program, and definitely Rwanda Pharmaceuticals Limited for sponsoring our program. And I would like to thank our honorable speakers and honorable academic experts for being with us. And I'm Dr. Mohammad Tanvir Ashraf saying bye-bye to you for today. Bye-bye.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.